So we're at the American Society of Tropical Medicine and Hygiene Conference, the 65th annual meeting in Atlanta, Georgia. And I'm here with Jean Richardson. Jean is an former infectious disease fellow and currently a PhD in anthropology. And he had a publication today that published in PLOS Neglected Tropical Diseases and was also a co-chair of a symposium yesterday that actually featured the results here at the meeting, talking about minimally symptomatic Ebola infection in survivors of during this most recent outbreak in West Africa.
The study came out of the work we did as clinicians early in the Ebola outbreak, and we were seeing the far end of the spectrum of very sick people and lots of deaths in the Ebola treatment units. But as scientists, in the back of our minds, we thought, you know, there's probably a lot of people with minimal symptomatics, or maybe minimally symptomatic, or maybe even asymptomatic out in the community. And so as the epidemic died down and we switched to more of a research mode, we thought, well, this is a question we'd like to answer.
Yeah, because in the literature, in some places the Ebola outbreak has occurred, there has been evidence of a symptomatic disease, but also even in the wildlife where we have reservoirs, and that shows that, okay, those animals might have Ebola, and because they were able to isolate the virus in those animals. So we thought like it's also potential for asymptomatic infections to occur in humans.
Dr. Mohamed Bailer-Berry is a physician with Partners in Health in Sierra Leone and one of the study's co-authors. He, along with Dr. Dan Kelly, infectious disease fellow at the University of California, San Francisco, presented during a session on Monday at ASTMH, which featured some of the latest research on Ebola transmission, clinical sequelae, and asymptomatic infection, which was co-chaired by Dr. Jean Richardson and Dr. Paul Farmer of Partners in Health in Harvard University, who was senior author on the study. I talked briefly with Dr. Kelly, who presented the findings from the study during the session on Monday.
And in our study, we went back to one of the villages that we had worked in towards the end of the epidemic in Sierra Leone, in a small district called Kono. And we identified all of the people who had lived in quarantine households. And this epidemic was in November of 2014 to January of 2015.
So we chose this village because it was well surveyed early in the epidemic, so that we thought we'd have good numbers of people that were symptomatic. And in this village of about 800 people, 100 to 110 households, there were 34 reported infections, 28 deaths, and 6 survivors. And surrounding those cases, there were about 200 people, 200 individuals that were quarantined. So we went back with the list and found the quarantined individuals and drew blood from them to see if, as contacts of these cases, that they might be seropositive for Ebola antibodies. And what we found is that of the, I think it was 182 people we surveyed, 14 individuals previously not known to have Ebola virus disease were identified as being seropositive. And further interviewing, we found that 12 of them denied any symptoms during the period of active transmission in the village. And so we labeled them minimally symptomatic, and then 2 reported symptoms, so we counted them as missed cases. So overall, those 12 out of the new denominator, 48, gave us data that potentially 25% of Ebola infections are minimally symptomatic.
There's a curious specificity that gets associated with reports of Ebola, and that specificity is probably not warranted. For example, that this is the 25th Ebola epidemic. How do we know? I mean, we don't have adequate laboratory monitoring capacity in much of the world where these epidemics occur, or that there were, for example, in this last epidemic, 28,000 cases. We don't know that. I mean, you can say, well, this is how I define a case, but the real important question is, did this person get infected with Ebola virus or did they not? And what this study shows at a village level is that a substantial number of people who were not classed as having had Ebola, they were in other words not cases, did have evidence of Ebola virus infection and minimally symptomatic Ebola virus infection. And that's important for a whole bunch of reasons. One, just to make us more humble about how can we know what's going on when we don't have an adequate laboratory system, surveillance capacity, or health system in general to take care of people when they're sick. And another is because we know that some patients with Ebola virus disease have sequelae, that is, they have complications that go on for years. So the most important one is probably blindness due to the inflammation of the eye. And surely it's right to worry that some of these patients who were missed in the way we were collecting numbers last time around may have complications like that, and they're treatable complications.
What this means for survivors is that it potentially changes the definition. So right now, the definition of survivor is somebody who was sick, admitted to an Ebola treatment unit, and received a discharge certificate. And it's an important definition because those individuals are now eligible for social benefits that range from free medical care to food packages to even jobs. If we potentially expand what it means to be a survivor to those that are IgG positive, it means there are potentially a lot more people in the pool who are eligible for benefits. And right now, there's certainly not the funds there to increase benefits to a pool this large. So perhaps this research could be used for a greater funding for survivor programs.
One of the most important take-home lessons, I would hope, is that this part of West Africa, the upper West Africa, Liberia, Sierra Leone, and to a lesser extent Guinea, are really, they're public health deserts, and that's why Ebola spreads. They're also clinical deserts, which is why Ebola kills. And I hope that people are disappointed that the number of people who were classed as cases of Ebola who died was way too high in this village. And we've got a lot of work to do to reduce case fatality rate, the number of people who die after they're classed as cases, but also to take a good hard look at those who are missed and make sure they're okay too. And so there's lots of reasons to pay attention to this study and to do more studies like it to get a better idea of just how large this epidemic was.
The Center for Innovation in Global Health is proud to be able to fund this study. Initially, Jean Richardson and Paul Farmer were unable to find funding to actually do the field research. At the CIGH, we are committed to getting people into the field and doing this sort of research.